The following podcast is part of a certified educational activity titled New Frontiers in Precision Immuno-Oncology, Leveraging Biomarkers to Refine and Expand the Use of Cancer Immunotherapies and Combinations. Access the entire activity and complete the post-test at peerview.com/FQK860. Downloadable slides and practice aids are also available.
Good evening, everyone. We're really excited to have you join us for this session on the new frontiers in precision immuno-oncology. My name is Justin Gaynor, and tonight I'm joined by two great colleagues, Dr. Kurt Schalper, who's director of the Tumor Immunology Pathology Lab at Yale, as well as Dr. Eddie Guerin, who's director of Thoracic Oncology at UCLA. So tonight, we've broken things down into two separate seminars. Each seminar will be about 45 minutes. And the first seminar is focused on the present and the progress with cancer immunotherapies and biomarkers through 2019. And so with that, to kick us off, I'd like to hand things over to Dr. Guerin, again, Director of Thoracic Oncology at UCLA.
So thank you very much. I have sort of an unenviable task here of trying to give an overview of where immuno-oncology is sort of at the present. This would have been very easy a few years ago, but now not so much. One of the easier things is to show the current approvals. There are, of course, really two different interactions that are being sort of drugged here. Ipilimumab, which is directed against anti-CTLA-4, and then several PD-1 or PD-L1 inhibitors that you can see here that are approved in a variety of different malignancies. So in trying to sort of organize some of the approvals, and we're not going to be able to go through every approval, one thing that I think is useful is to look through sort of this slide, which goes through the TCGA data and shows the number of mutations per tumor. And it's interesting because if one looks, melanoma is the most frequently mutated tumor, followed by lung squamous, lung adeno. It looks essentially like you're marching through the approvals of PD-1 or PD-L1 inhibitors. Here you see the timeline of approvals. I won't spend a lot of time going through each of these, just to say that over time in solid malignancies, you have seen a tremendous number of approvals from the first approval in March of 2011 to the approvals in melanoma in 2014 to what is now just a tremendous amount of immuno-oncology. So this, of course, is data from the initial data set that led to approval of immuno-oncology agents, or at least the immune checkpoint inhibitors. This is ipilimumab in relapsed metastatic melanoma, and you can see here with the tail of the curve the reason for the tremendous enthusiasm regarding this drug class. This tremendous number of people who are out 120 months. I'm sure that it wasn't very long ago that melanoma physicians would not have expected ever seeing a curve going out to 120 months. That really is much of the promise, but it also illustrates how drug development has generally gone, which makes sense. In general, you start your evaluation with patients who really don't have other good options with metastatic relapsed disease. Then over time, move more towards a metastatic first-line setting. This is a group that still has a lot of incentive to enroll on trials, but maybe has better therapeutic options, and eventually to earlier stages of disease, including patients who could theoretically be cured by standard therapy alone. Here you can see the approvals for pembrolizumab and nivolumab in previously treated relapsed metastatic melanoma, and just the progression that I had showed before is really what one is seeing here. You moved subsequently to first-line metastatic melanoma. You can see the curves here. And then eventually to adjuvant therapy. Here you see in the upper left, ipilimumab. Then you can see curves looking at pembrolizumab, but also curves that show both ipilimumab and nivolumab, showing that over time we've even been able to increase the degree to which this can be an effective approach in melanoma. So again, sort of marching down the both the TCGA atlas and the sort of approvals, you can see data from relapsed metastatic non-small cell lung cancer. Here you see the data sets that led to approvals, eventually moving to the first line. Here you see is basically a substitute for chemotherapy, and more recently, several combinations that lead to actually not just substitution, but additions to chemotherapy, leading to approvals in non-small cell lung cancer and showing positive data in small cell lung cancer as well. And again, this has moved earlier into treatment. In lung cancer, we still don't have adjuvant data, but we do have data from locally advanced disease, which is a very dire clinical situation, but one that is still theoretically curable. And there, durvalumab has shown benefit over placebo after chemoradiotherapy. I'm not going to belabor this for each of these, but again, marching sort of right down the TCGA mutational burden chart, you can see urothelial carcinoma, where again, you have multiple different agents that are approved. One that I think is interesting to point out is colorectal carcinoma. Here you can see that it doesn't fall necessarily to the middle, but it's not the top in terms of mutations. But you do see this group of patients with a very high mutational burden at the very top of what you see in the red box here. And it has now been nicely shown those are presumably patients who are MMR deficient, and you can see that that is a group of patients that clearly did better when they received pembrolizumab, and we now have data comparing nivolumab to nivolumab ipilimumab, and these are approved approaches in metastatic colorectal cancer, but again, based specifically on those patients who have MMR deficient tumors. So I just included this slide because I wanted to point out that this is not exactly a perfect system here in terms of predicting, and there are multiple potential reasons for this, but kidney cancer, for instance, which has traditionally been considered an immunoresponsive tumor, there we do have positive data for immune checkpoint inhibitors. You can see that data shown here, and so there are potential reasons for that, but as is often the case, things aren't that simple. There are presumably multiple other factors that are sort of driving this, but we do now have approval across multiple different histologies.
Great. I think that was a terrific introduction, giving you a lay of the land. So much has changed over the last several years. And so now to introduce biomarkers, I'd like to invite Dr. Schalper to speak to us on phenotype and genomic determinants of response to immunotherapy.
Thank you, Justin. Thanks for the invite to be here. And it's great to be able to now show the perspective of the pathology. We're actually the guys running most of the biomarkers. And things have gotten quite complicated, similar to what you saw in the previous charts where we see multiple tumors, different biologies. This is a summary of some of the biomarker landscape where we have what I call immune or phenotype biomarkers, which are on the upper side, and then we have what I call tumor or genomic markers, which are on the lower side. The most important thing is that as this progresses, there have been approvals, and there are some biomarkers in this list that are already clinical. So as of today, there are 2 biomarkers, one from each category, that are regulatory approved for use in certain indications, and one of them is PD-L1, and the other one is microsatellite instability. However, there is a little bit of a gray area because we happen to find metrics that are not approved that are being reported in FDA-approved tests, which is the case, for example, of mutational burden and discrete gene mutations that are reported in things like Foundation 1, which is FDA approved. So we have a little bit of a gray zone here, and it's probably going to evolve further. So first, I'll discuss a little bit further about PD-L1. And to really understand this, we have to go and look a little bit at the biology, although we don't completely know what it means. It's pretty clear that PD-L1 upregulation is a mechanism of peripheral tolerance. Essentially, in this case, in the tumors, what we believe is going on is that upon antigen presentation and recognition, as shown here on the left side of the slide, normally we see attraction of lymphocytes, and then those lymphocytes come close to the tumor in the tumor microenvironment and start producing interferon gamma, which by itself starts engaging into interferon gamma receptors and mediates what we call extrinsic pathway or interferon gamma-mediated PD-L1 upregulation. Interferon gamma also can upregulate PD-L1 in other cells, such as macrophages and immune cells around it. Tumor cells have evolved to also suppress immunity, and they also have built-in mechanisms by which they can upregulate tolerogenic pathways. And that's what we call the intrinsic pathway, by which some clear oncogenic signaling, PI3 kinase or PTEN downregulation, can also upregulate PD-L1, essentially turning this hot tumor microenvironment into a cold one. The traditional way we use to detect PD-L1 is using immunohistochemistry. And as shown here, essentially we detect deposition of a brown pigment that reflects the presence of the protein. And we can, by looking in the light microscope, see if there is in the tumor cells, in this case in a well-differentiated adenocarcinoma, but also, as you can see, in immune cells that are in the stroma. One of the problems is that PD-L1 as a biomarker has been co-developed together with some of the treatments, many of which Eddie showed in his presentation, outlining a complex scenario where we have different drugs, some of them targeting PD-1 and some PD-L1, but each of them uses a different biomarker to detect the same protein. And this is the case for example, 28A, 22C3, and so on and so forth. What I want to emphasize now is that there are two scenarios in which PD-L1 testing is indicated as a companion biomarker for frontline treatment of lung cancer, in this case, when it's more than 50% expressed in the tumor cells, or in bladder urothelial carcinomas, when it's expressed in more than 5% tumor or immune cells. Companion biomarker means that it is in the label of the drug and it needs to be tested to be able to initiate treatment. One important question when we have such a complicated scenario for a single marker is to try to understand if they are comparable. And this study, fortunately, came out comparing 5 of these biomarkers or PD-L1 assays developed against the same protein in the same cases. And as you can see already, we see that some of them are dimmer, as SP142, and some of them are much stronger, like 7310. When this is actually quantified and scored by multiple pathologies, it's very clear that one of the assays, SP142, shows lower score overall, and one of the assays shows higher scores, essentially supporting that not all PD-L1 assays are equivalent, and at least 2 of them are very different from the other ones. The other important point is that I just mentioned, sometimes we call this marker in the tumor cells and sometimes in the stroma. And this is the correlation of multiple pathologies scoring multiple assays in tumor cells. And you can see that the correlation coefficients are between good and excellent, meaning that we pathologists can reproducibly score tumor PD-L1 signal. However, when we look at the correlation of the stromal cell culling, then we see that the correlation drops dramatically, supporting that scoring PD-L1 in stromal cells is not reproducible. This is very important because more and more data is emerging supporting that stromal PD-L1 signal is relevant. One important point when we test PD-L1 is to try to understand what are the sample requirements to be able to test it reliably. And there are 2 general approaches. One of them is the optimal quality that we typically look for any IHC assay, including hopefully recent disease or current disease. Abundant tissue, we usually ask for this amount approximately. We like to have many tumor cells to be able to call that reliably, and also proper tissue processing. But specific for PD-L1, we have learned a few things. For example, it seems like PD-L1 scores are stable for up to 2 to 3 years, and I'll show you some of the data. And also, there are minimal metrics to be able to call it, at least for some of the assays. In this case, it's any tissue area containing at least 100 viable tumor cells for 22C3 and 28A, which includes the companion biomarker for lung cancer. The tissue processing is not different from anything we have done before. And this is an example of a small case that you can see here is only probably 1.5 millimeters, but we do have 100 cells, so this is the type of samples we score when we have advanced lung cancer. This is some of the data supporting the likelihood of being positive in different scenarios. And what you're seeing here on the left and on the right are 2 studies looking at primary and metastatic lesions from the same tumors. And you can see that the concordances are pretty high, in the range of nearly 80% for one study using SP142 and about 75% for another study looking at E1L3N. However, you can see that the high concordance is predominantly driven by the negative scores, which are the vast majority in both studies. And when we look at those scores that are higher, the concordance is actually not so good, supporting that this is maybe not the best thing to do. Then when we look at the time of the tissue diagnosis to PD-L1 measurement, there are two experiences reported, one from Brigham, Pasigianni's group, where he showed that tumors that are more than 3-year-old show a dramatic drop in the frequency of PD-L1 positivity, that it was statistically significant. And then there is another study, the Atlantic trial, showing that, again, after 3 years of disease elapse, the dramatic drop in PD-L1 goes to about 40 or 50%. Again, supporting that these samples may not tell us reliably the level of PD-L1. There is also data supporting that PD-L1 can actually be quite stable even after treatments. And this study included 32 specimens treated with neoadjuvant chemotherapy, showing that the tumor signal changed, but the stromal signal was stable. And this is another study presented at the World Lung, where it was shown that nearly 75% of patients treated with chemotherapy or targeted therapies did actually maintain PD-L1 expression after treatment. And those cases that show changes typically had increase in the signal and not dramatic loss. So despite all the concerns, it seems like PD-L1 is a fairly stable marker. So now, regarding microsatellite instability, essentially the way this works is that there are mutations in DNA repair proteins that start introducing multiple single nucleotide variants into areas called microsatellites, which are enriched in mononucleotide sequences. And these mutations or this genotype is associated with a number of different tumors, sometimes syndromes when it's germline, or specific tumors when it's sporadic, but typically includes both mutations and absence of the protein by methylation. One important thing is that the frequency of microsatellite instability is very different across tumors, and we see here that uterine carcinomas show a very high level of about 30%, and then colorectal and stomach carcinomas have about 20%. So one question is here, should we reflex test all of this? Most institutions are doing colorectal carcinomas reflex testing, but not the other tumors. And then there are questions about how much methylation or how many loci need to be unstable to be able to call. And I think with further assays, we're going to learn more about this. How should we test for microsatellite instability? There are two traditional assays. One is immunohistochemistry, using 4 different markers that are indicated here. And then we have a molecular test looking at the consequence of the loss of these proteins, essentially interrogating changes in microsatellite loci. To date, I think most of the data has been done using either one of these assays, essentially supporting that today the current standard assay to detect microsatellite instability is immunohistochemistry or a molecular test. There have been recent concerns because it has been shown that a fraction of tumors, particularly when they're germline mutations, they can have in-frame mutations that affect the protein function but don't eliminate the protein. So they can be positive by immunohistochemistry, but they show absence or presence of microsatellite instability in the molecular test. And this fraction is estimated to be about 10%. So recurrent recommendations suggest that we should do probably both and screen with immunohistochemistry as a rapid way to assess and then confirm with the molecular test. One important caveat of the molecular test is that as opposed to the immunohistochemistry, it requires both tumor and non-tumor tissue from the same patient to be able to do the comparative analysis. And it also requires more sophisticated installations not frequently available. So it's not easy to do it in every patient, but it's currently probably the best idea to not miss the germline variants. And finally, I will quickly talk about tumor mutational burden, which Justin will talk more about. But the way we think this is operating is that tumor harbor mutations that can change amino acids that at this point can be recognized by the AMH system of the patient and can be recognized as non-self. And this is, at this point, the fundamental idea of why tumor mutational burden connects with the immune system. There has been retrospective data showing that increased tumor mutational burden is associated with better outcomes in patients treated with immunotherapy, and it seems like it's not prognostic because it doesn't seem to do the same in patients without immunotherapy. However, there are multiple assays now trying to deal with this, and Justin will expand more, but I think one important decision is how much sequencing we need to do and how much is required to capture this metric across the genome. And also, it's clear that not all the assays are the same, because here, when we compare whole exome as the standard with foundation panel, we see that a fraction of patients actually are misclassified if we believe that whole exome is the reference. So it's very important to standardize this assay, and also to identify cut points, as shown here, for example, where it seems like 16 mutations per megabase allows to identify a prominent hazard ratio in a meaningful population of patients, and which is actually very important because it could explain partially at least why CheckMate 227, that was positive for progression-free survival, was negative for overall survival, including a lower cut point of 10 mutations per megabase. So at this point, tumor mutational burden is not an approved biomarker. It's still a metric that needs to be standardized for clinical use. So finally, there are a few technical differences in the sample requirement for whole exome relative to targeted assays that drives the need to hopefully do targeted assays that work. And they're essentially related with the amount of tissue required to do whole exome, which is rarely available for patients with advanced tumors, and also relative to the coverage of the whole exome assay, which is usually in the range 200 to 200x as compared to targeted assays that can achieve much higher coverage and more sensitivity to find low abundance mutations. So with that, I think we conclude that biomarkers can be used to support optimal clinical use of immunotherapy and hopefully development, that PD-L1 and microsatellite instability can be tested. They are approved, and they are standard platforms to be able to do them. They're widely available, but there are refinements ongoing to do them better. But the technical sample and analytical considerations are critical. We need to do them right. TMB is associated with outcomes in patients treated with immune checkpoints, but the assay is still not standardized, and a lot of efforts, and Justin will talk about that, are ongoing to try to have a common designation. And finally, novel biomarkers are being developed and will likely impact the field, which I will discuss in my next talk. Thank you.
Great. Thanks so much, Kurt. I think that's a perfect segue into a discussion of, so how do those biomarkers, and you just heard a lot about the technical aspects of them, how have they rolled out into the clinic, and what is some of the clinical data behind them? So you've seen little sneak peeks at that. The goal of my talk is really going to be to summarize 3 of these genomic platforms, or genomic metrics. The first, a little bit more on TMB. The second, looking at certain single genomic biomarkers of resistance to therapy, and then a little bit more on the clinical data on MSI status. So we'll start with TMB. We just heard an excellent overview of TMB. But I think it's worth just taking a step back and looking at really the explosion of data over the last just 4 years. Some of the first descriptions of TMB as a biomarker were just 2014, and now this slide shows now a flurry of activity exploring this in multiple different diseases. And so I think some of the key clinical considerations, just to echo some of them that Kurt already mentioned, is, what's the clinical utility of TMB? Second, what's the relationship of TMB with PD-L1? Is it predictive or prognostic? What's the optimal cutoff, and should we be measuring this in tissue versus plasma? So these are just some of the things that I hope to address today. So first, just a little bit on how this biomarker emerged. The earliest data that we saw was in the melanoma space. This is data from Schneider et al., published in the New England Journal in 2014. And this is data with CTLA-4 blockade, but showing for the first time that mutational load, which is really a surrogate for the amount of neoantigens that are in the tumor, was predictive for both clinical benefit as well as survival in patients treated with CTLA-4 blockade. In the subsequent few years, we then saw that this extended to PD-1 pathway blockade and extended to other disease areas. So this is work by Nair Rizvi and colleagues showing that in a subset of about 30 patients with lung cancer, that mutational load also correlated with clinical benefit in non-small cell lung cancer. And importantly, a subsequent analysis of that same data set showed that it's not just the number of mutations that are present, but the clonality of those mutations also mattered. So for example, on the y-axis here, the number of mutations, and this is based on whole exome sequencing. And this is color-coded, so you can, on the left, you can see underneath there's a green bar that's durable clinical benefit. So these are the tumors that had durable clinical benefit, and these are the tumors that had no durable clinical benefit. And so you may ask, like, what about these two tumors? These have very high mutation loads. Why aren't they benefiting? In blue, these are clonal mutations, and in red, these are subclonal mutations. So the clonality of those mutations matter. If you have lots of subclonal mutations, the immune system can pick those off, but it's really those truncal mutations that actually may be more relevant. More recently, we've seen this play out in multiple malignancies. This is work by Ellie Van Allen's group, where they did whole exome sequencing, not just on melanoma and lung cancer, but bladder, head and neck, and other cancers. And again, the same story plays out, that number of mutations influence responsiveness to PD-1 pathway blockade. All of the data I've shown you so far, these are all retrospective series, and they were done mainly using whole exome sequencing. And so the question is, well, what happens when we start looking at prospective data? And so this is one of the future studies that we have with prospective analysis of TMB. This is CheckMate 227. It's a complicated design here, but breaking it down is this study looked at non-small cell lung cancer and evaluated chemotherapy versus PD-1 monotherapy versus chemo plus PD-1 versus PD-1 plus CTLA-4. But without getting into the nitty-gritty of it, essentially one of the co-primary endpoints was based on TMB high patients. And to first talk a little bit about the clinical data, it's worth mentioning how they established the cutoff in this study. So they actually established the cutoff using a separate study, CheckMate 568. On the left, you can see some ROC curves where they looked at TMB, and they found that 10 mutations per megabase based on Foundation 1 assay achieved the best performance in this phase 2 study. And importantly, this TMB estimate was independent of PD-L1 expression. So these look like separate biomarkers. And that's illustrated by that central figure there. And this cutoff of 10 mutations per megabase actually affects a fairly sizable number of patients. You can see about 44% of patients in CheckMate 227 had a high TMB by that definition. So it's not an insignificant number of patients. And here's the primary endpoint. You can see that the combination of nivolumab and ipilimumab led to an improvement in progression-free survival among the high TMB group. And based upon these data, a regulatory package was submitted to the FDA. And we recently learned, and this is based on press release, that when the overall survival was looked at, in the high TMB group, there was a trend towards improvement with nivo-ipi compared to chemo, but also a trend towards improvement in the low TMB group as well. So I think it's still open, in my mind, how predictive versus prognostic in TMB can be. And it may be a little bit of both based upon these data. I think we need more follow-up. As Kurt already mentioned, there are a number of different ways to select TMB, and I think at the core of TMB is really the standardization question. The gold standard to this point has been whole exome sequencing, where you're looking at the whole genome, whole exome rather, looking about 30 megabases, versus more targeted next generation panel-based, where you're looking at a much smaller segment of the genome, and so raising the question of how much dynamic range will you have if you use a targeted approach. Not only is it the amount of sequencing that's done, it's also what you're actually counting as a mutation. Are you counting non-synonymous mutations only? Or are you counting synonymous and non-synonymous? Are you counting frame shifts and insertions, deletions? These are still open questions. And if you look in this table, you can see that each of these counts things just a little bit different. Not only that, the total number that you're using to define high TMB differs across diseases. I know this is a lot of fitting in one table, but the details are less important, but it's really meant to show you that the threshold to define TMB differs in all of these studies, and it's all over the place. And so I think moving forward, there needs to be an effort to try to harmonize this, much like was done with PD-L1 expression in lung cancer, such as in the blueprint analysis. So the Friends of Cancer Research have launched this effort to harmonize TMB, and it's really trying to put together all the key stakeholders. This includes test developers, pharmaceutical companies, FDA, the National Cancer Institute, academia, and they've proposed a three-pronged approach that includes in silico analysis based upon existing data, as well as empirical analysis and clinical analysis. And the hope is that putting this all together, we can come to some kind of standardization around TMB. I think in addition to just defining cutoffs and what we're counting, the next question is, plasma-based testing is here, it's not going away. How do we then incorporate TMB into plasma-based testing? And so this is recent data published by David Gindera and colleagues showing that you can measure TMB in the plasma. This is based upon a lung cancer study. But again, this metric, this cutoff is different from all the others. So how does this fit in versus tissue? I think it's still to be determined. In the last couple minutes, I just wanted to say a few words on the clinical implications of single biomarkers on the genomic level. So I've mentioned TMB, which is really the 50,000-foot view of cancer genome, but there have been in recent years several single genetic alterations that can give us some indication about responsiveness to checkpoint blockade. And so STK11, aka LKB1, is one such example. This is work published by Nando Skolidis from MD Anderson, and he just showed the presence of just STK11 mutations. These tumors, this was a lung cancer paper, but these tumors were much more resistant to checkpoint blockade. And so STK11 is one of these negative predictors, just that single genetic alteration. Likewise, in lung cancer, EGFR and ALK alterations also indicating intrinsic resistance to PD-1 pathway blockade. And these make sense. These tend to be enriched for never smokers. And so the TMB of these tumors is likely to be far lower than your typical smoking-induced lung cancer. But examples of where you might not need TMB, you just get a better estimate just with this single genetic alteration. And then in the closing couple minutes, just a few words about microsatellite status. You heard an excellent summary of the mechanism behind this from Kurt, but I think it's helpful to take a step back of how it even came about, why we learned that checkpoint inhibitors may be active here. And I think this is a classic example of where we can learn amazing biological insights from a single exceptional responder. So in the initial phase 1 studies of PD-1 inhibitors, they saw one patient with colorectal cancer respond. In this table, it was 0, but subsequently went on to have 33 colorectal cancer patients, and one of them responded. It was the one patient with microsatellite instability. And so that really launched a series of studies, prospective studies, looking at the role of checkpoint inhibitors in tumors with deficient mismatch repair. And you can see here that nice responses observed in those groups. And not surprisingly, when you look at the correlatives, these tumors have much higher TMBs compared to mismatch repair proficient tumors. They're more inflamed tumors, more CD8 cells, and more PD-L1 expression. And now we've seen that PD-1 inhibitors are really active across multiple solid tumor malignancies that are characterized by this deficiency. And for the first time, an FDA approval in a tumor-agnostic fashion. So regardless of tumor of origin, if you have microsatellite instability, you can use a checkpoint inhibitor. So really changing the paradigm of how we approach these tumors. And I think a question for the clinicians then, and Kurt showed a different variation of this, is we can see mismatch repair deficiency across multiple different tumors, but the frequencies start getting really low. So how should we start testing these patients? If something's got a frequency of 1 to 2%, should we be testing that for mismatch repair deficiency? I think, and how should we be doing it? I think those are some of the open questions. So I illustrated them here. What are the approaches to screening? What are the implications of germline versus somatic mismatch repair? Are they going to respond differently? And should we be using monotherapy versus combination therapy? Still open questions. So to summarize, beyond PD-L1 expression, we now have several genomic predictors of response. PD-1 pathway blockade is now a standard for mismatch repair deficient tumors agnostic of tissue of origin. And TMB is an emerging biomarker, but questions remain regarding standardization. Okay, so with that, I think we're going to take a few questions, and we're going to maybe have Kurt and Eddie. Maybe we'll start with, for Kurt, how does sample preservation affect TMB?
Yeah, so this is an interesting question because as opposed to what we have learned with PD-L1, we don't know much about TMB per se. What we do know, though, is that DNA is a very stable molecule. It's actually a double-stranded molecule, and that helps preserving. So we rarely see problems in having stability of the DNA in the tissue sample. So I would think that TMB will be a stable marker in the conventional samples, but there is no data yet to prove that and decide how far back we can go.
And so, Eddie, one question here is, since biomarker sensitivity can change with treatment, where does liquid biopsy fit in patient management right now?
Sure. So it's a little bit interesting. Although we have seen that certainly some of these biomarkers can change over time, we don't necessarily know if the extent to which that affects, or if it affects interpretation of the test. Now, in terms of blood biomarkers, one could imagine that it certainly would change potentially based on treatments. And one of the particular concerns I would have is in blood-based TMB, because my sense of blood-based TMB is you're really testing for two separate things. One is you're testing for the number of mutations that are present in the tumor, but the other, you're testing for the degree to which the tumor is shedding DNA. And since that second component certainly can at least change, one does have to be a little more skeptical. However, in all of these questions of biomarkers, in the end, I think you're dependent on what the clinical data shows. And so the clinical data from Oak and Poplar did show this nice correlation with blood TMB. There's also data now showing a nice correlation with blood TMB as part of the MYSTIC study. And so what I think is going to be important in both of those instances is to see whether or not that is validated in subsequent studies, because of course one can always retrospectively go back to a data set and try and pull something out of it. But the big question is, can one use it to prospectively predict what's going to happen? And that I think we're still waiting to see.
And Kurt, you showed nicely a lot of the data behind PD-L1 expression and some of the nuances between the different tests. In the studies that established PD-L1 expression as a predictive biomarker, they were always core biopsies. There were always excisions or resection specimens. But in the clinical world, commonly we're dealing with cytology specimens. Can we use those samples for PD-L1 testing? What do you do in clinical practice?
Yeah, so this is it's a great question because there's no prospective study selecting patients based on cytology specimens, which is always not great. But there is a numerous studies showing high concordance between cytology specimens with more than 100 tumor cells and biopsies with more than 100 tumor cells. So today, based on the data, it's acceptable to use a cytology as long as it meets the requirements, but there is no prospective study, so it's the best we can do today.
Great. Okay, so we're going to have another question and answer session after the next session, but I think in the interest of time, we're going to move on to part 2, which is meant to be the future of immuno-oncology. And so with that, I'll kick things off, and so we're kind of reversing order here. And so my job is to talk in 10 minutes to try to summarize combinations, which I think we could spend 10 days talking about. So how do we do that? My mission here is really just to provide a framework. So how should we think about combination therapy? And I think everyone in this room is familiar now with the problem is, that despite the success of checkpoint inhibitors in so many different malignancies, that a majority of patients will not respond to therapy. And so we clearly need to improve upon these outcomes. But, how do we do it? So everyone's eager to look at combinations. And for me, I turn to the cancer immunity cycle as a helpful framework. This is really, what has to happen for your immune system to recognize and effectively kill a cancer. And I think we can overlay on this cycle various therapeutics that can manipulate various aspects of this cycle. And for me, this is a helpful way of thinking about it. So I want to talk a little bit about certain nodes along this axis and give you some examples of what's been tried, what's been successful, and what has been less successful. So I think we'll begin in the bottom left, and really I'm going to focus here on chemotherapy. And I would say this is, while hasn't been the most scientifically interesting, it's been the most successful so far. So in lung cancer, we now have multiple randomized studies showing that addition of checkpoint inhibitor to chemotherapy improves overall survival in patients with non-squamous, squamous, small cell, and we've also seen now data in breast cancer. Below, this is the Impassion 130 study where atezolizumab was added to nab-paclitaxel again, where we saw a survival benefit was in the high PD-L1 expressors, but an intriguing result. What about other things? And most notably, I think the central question and the thing that is really the hardest thing to do right now is how do we turn a cold tumor hot? Really, that would be the magic combination if we gave something that turned immunologically cold tumors hot. And so I just wanted to talk about a few different strategies. For the sake of time here, I'm just going to focus on vaccines and oncolytic viruses. This is a publication from Patrick Ott and colleagues, published in Nature in 2017. And what they did here was they took a biopsy, they did comprehensive sequencing of that tumor, and they identified potential neoantigens. And this is based upon the genomic sequencing, HLA typing, doing some in silico analysis to find what's the most likely neoantigens. Because I don't know if we explicitly made the point in the last session, but just because you have lots of mutations doesn't mean you're going to generate something that an immune system is going to recognize. It's really just a small fraction of it. So in this study, they tried to identify the most immunogenic alterations and develop personalized vaccines for these patients. This was a small number of patients, and there are 6 illustrated here. And they developed peptide vaccines, and they could identify immunologic responses to these neoantigen vaccines. And so I think this is one really interesting strategy moving forward. I think we have to think about, one, will it be effective? What disease areas is it going to be effective in? Is it going to be the minimal residual disease kind of adjuvant state? And how do we operationalize this? How do we do the sequencing, design the vaccines, et cetera? A strategy to turn cold tumors hot would be to use oncolytic viruses. These are directly injected into one tumor lesion, and the thought process is inducing rupture of tumor cells from the oncolytic effect, and that in turn leading to a systemic immune response. There is one oncolytic virus that is now actually marketed in the United States, and this is TVEC. I frankly can't pronounce the full name, so I'm just going to say TVEC. And this is now approved in the US for patients with melanoma. It is a monotherapy based upon this randomized data to the right. There have now been data with TVAC in combination with ipilimumab, and a study that has completed accrual in combination with PD-1 pathway blockade. So I think this is another strategy trying to turn cold tumors hot. And there are now multiple other oncolytic viruses that are currently being explored. Continuing around the cancer immunity cycle, I would talk about cytokines, and really cytokines are making a way back. Cytokines were some of our earliest immunotherapies, IL-2 being one that is approved, but the challenge of IL-2 had always been a low response rate, but lots of toxicity. Recently, we've seen data from the next generations of cytokines, so this is Nectar-214. This is a CD122 biased agonist, and it's a pegylated form of IL-2, and the conjugation is meant to mask the region of IL-2 that interacts with the subunit responsible for activating T regulatory cells. So you're really just trying to focus on the T effector cell component here. And we've seen now in initial reporting some intriguing preliminary results in renal cell and melanoma, but I think we really have to see what these data look like with more patients. I should note that in stage 2, these response rates include the patients from stage 1. And these are PD-1 naive patients. And so we know that melanoma patients, RCC patients, can respond to just PD-1 pathway blockade monotherapy. So is there some selection here, or is there something about this combination that is particularly active? I think we need more data to sort that out. In the closing 2 minutes, I just wanted to say a brief word about anti-VEGF therapy. We do know that VEGF may contribute to an immunosuppressive tumor microenvironment for a number of different ways, ranging from decreased trafficking to effects on MDSCs. And really, in the last year, we've now seen some interesting data looking at the combination of chemotherapy plus PD-L1 plus bevacizumab. And this is a complicated design, 3 different arms, breaking it down: chemo plus IO versus chemo, IO, bev versus chemo, bev. And the bottom line here is the quadruplet did result in an improvement in progression-free survival as well as overall survival compared to chemotherapy plus bev. So it does look like there's probably some interaction between the angiogenesis inhibition as well as immunotherapy, but I think we really need to sort that out. And then finally, alternative checkpoints and immune metabolic checkpoints. This is data from the melanoma space. So these are post-PD-1 patients who are treated with LAG-3 plus PD-1. And you can see that there is some responsiveness, but I think we need to sort out what are the appropriate biomarkers in order to take this forward. The response rate here is 12.5%. And then to close really with a cautionary tale of taking phase 1 kind of early data and jumping straight to phase 3. This is the IDO experience, and we can see that it was promising in the phase 1 setting in the initial expansion cohorts, but when taken straight to phase 3, it really looks like one curve, not 2. So I think what this means is we need better preclinical models, we need better biomarkers, and I think we need innovative clinical trial designs to sort out the difference. And so to conclude, immune checkpoint inhibitors have reshaped various malignancies. As only a subset of patients respond, we need better combinations, but we really need novel strategies and designs to make that happen. Thank you. Now I'm going to hand the ball back over to Kurt, who's going to talk about what are the next wave of biomarkers to help make those trials happen. So Kurt.
Thank you. So as you can imagine, things are not going to get any easier. And to think about it, I thought, and I'm doing a little bit of a guesswork of what I believe are going to be the next generation of biomarkers, first thinking about approved therapies, and then I'll touch a little bit on biomarkers for potential new therapies. So I divided this set of slides in 3 sections. The first one, I'll talk about refinement of biomarkers that are already being used. and I'll touch on blood TMB and some of the RNA signatures, and then touch briefly on markers beyond PD-1. In the second part, I'll talk about how we can integrate biomarkers that are non-redundant. And this is actually very interesting because we're now seeing data from trials showing that this is actually possible. And finally, I'll close with sort of a future vision of where this is going and show you some interesting data. So one important thing about some of the tumor biomarkers is that somehow they can be detected in circulation. And as you can imagine, there are a number of different things in blood and plasma that can be detected, but circulating tumor DNA is actually quite stable, and probably for the same reason, is a structure that it's well protected from DNases. So it can actually survive, and it's a very small fraction, but it has a short half-life, but can be reliably measured if the samples are collected and processed adequately. And this is very interesting because it's a window to the tumor, but just looking at peripheral blood and without having to take biopsies. So there has been some data, like what Justin showed from Dave Gandara, showing that blood TMB can actually provide information. And there is more data, and this is a recently presented study, the MYSTIC, showing the effect of durvalumab, essentially blocking PD-1 and CTLA-4 with or without chemotherapy. It was a negative trial, so all the endpoints were negative. But what was interesting is that using a blood TMB measurement with a cut point of 16 mutations per megabase, they were able to identify a benefit in the patients treated with the combo that was significant for overall survival at 2 years. So again, this is a sub-analysis. It needs to be confirmed, but points out to the notion that maybe this type of metrics will rescue some of these studies. But the interesting thing is that also this MYSTIC study used a novel blood TMB assay that is called the Guardant Health Omni, which is a next generation of assay that includes a high amount of sequencing in nearly 500 genes, including in this case nearly 2.1 megabases. So it's a vast amount of sequencing, probably able to capture more, and it correlates well with whole exome sequencing data, as you can see there. So what I'm trying to say here is that the future of biomarkers in blood is having considerably more power to detect variants from the tumor in circulation, and we're seeing that this actually pays. Another important thing that has been lingering for a while is how to capture this inflammation as a biomarker. And it actually has been quite difficult because inflammation in itself is difficult to measure. It's a very complicated process, and it's also in itself prognostic. They were essentially creating gene signature using, in this case, 18 selected gene transcripts that were associated with response to treatment, and they created what they call GEP, or gene expression profile. In a recent study, they show the value of this gene expression profile in 3 cohorts from patients treated in their clinical trials. And as you can see there was a significantly higher level of this inflammation metric in patients that were responsive. However, if we look at the data very carefully, it was very clear that a lot of the heavily inflamed tumors, and actually the most inflamed tumors, were in the non-responders, pointing to the weakness of this type of approach. Another strategy that we can use to capture these metrics is using multiplex immunofluorescence, and this is data from my lab showing that by combining measurements of T cells and granzyme proliferation of T cells, we can actually also predict survival. And again, these assays need to be refined and cross-validated. The important point about showing the effect of alternative molecules beyond PD-1 is that there might actually be a relationship between expression of other targets and their inhibition. And this is the same slide Justin showed with the effect of an anti-LAG3 after patients already progress on PD-1. But the most important point from my view is that if you can see, the response rate was 3 to 4 times higher in patients with baseline expression of LAG3, supporting that expression of the target is somehow connected with the likelihood of response. And it's quite encouraging to think that we may be able to run next-generation clinical trials using biomarkers instead of just waiting for the negative trial and go back and look at the exceptional responders. So now, relative to integration of biomarkers, we have learned a lot. And this is a study, actually, Justin and myself were involved, where we look at the correlation between PD-L1 and tumor mutational burden in a set of non-small cell lung cancers. And one thing that we could see is that there was not a direct correlation, and actually they were pretty much anti-correlated, which again supports that they're non-redundant and they may be potential for integration. And the clinical output of this was done in a sub-analysis from the study CheckMate 26 that treated patients with and measured PD-L1 biomarker and also TMB in a subset. And as you can see here on the right, the combination of patients with high PD-L1 and high TMB did considerably better than any of the other arms, again supporting that these biomarkers are not only non-redundant but can be integrated. And this type of studies will now be tested prospectively so that we can understand how to use them. This is again a study published by my lab where we look at the relationship between tumor mutational burden and tumor immune infiltration. And what was actually surprising is that those tumors with the most mutations were actually not the most inflamed, which kind of, it's counterintuitive based on what I told you in the previous talk. But it could be actually that those tumors that have genomic instability can adapt faster to immune pressure. And that could be why they don't see a correlation between mutations and inflammation. As you can imagine, this has also been confirmed in the studies by using the RNA expression profiling. And what you can see here is that in the 3 different cohorts, there is no correlation between the gene expression profiling inflammation metric and the number of tumor mutations, again supporting that these metrics are non-redundant. In this study, they went actually forward and they combined looking at progression-free survival in 3 different cohorts, tumor mutational burden with gene expression profiling. And what you can see here on the top right, it was actually the possibility of stratifying the patients further, combining inflammation and tumor mutational burden. Again, supporting that at least we have 3 metrics that can be integrated, 1 being PD-L1, 1 being mutations, and now 1 being inflammation signatures. So now we're going to have a look at biomarkers that go beyond what we already know. And in this case, I divided this in 2 segments. One are tissue biomarkers, depending on tissue visualization, and then I'll talk a little bit about serum or circulating biomarkers beyond circulating tumor DNA. And one of the things that I actually have been heavily involved is now using computational biology, in this case machine learning, to try to extract more information from conventional H&E sections. And this is a study that was reported by our team in ASCO, showing that just extracting a number of features and applying machine learning classifiers, we can predict response to immune checkpoints. And this is now being validated in a separate cohort. We did already 2, but now we're validating further. And this could be actually a very interesting way to further enhance our biomarker without having to do so much molecular measurement. Another possibility is not only to measure H&E, but to include different markers. And there are different platforms. I already showed you some data with multiplex immunofluorescence, but there are other technologies like imaging mass cytometry, MIBI, nanostring DSP that allow multiple and high-order multiplexing. So now we can actually phenotype numerous types of cells and measure both tumor and immune markers simultaneously. And we have shown already, and there's work ongoing, showing that there is a possibility to create machine learning-based predictors integrating both tumor and immune metrics to predict outcomes better. And I predict that we'll see a lot of that coming in the next couple of years. Now, looking at serum data or circulating biomarkers, there's very interesting data presented by Pam Sharma at AACR last year, showing that actually the baseline level of myeloid-derived suppressor cells, in this case characterized by the expression of CD11B and lack of HLA-DR, was actually associated with lack of response to PD-1 blockade in patients with advanced bladder urothelial carcinomas. Again, this is a non-DNA cellular-based biomarker that could be used to predict and to eventually monitor patients. So again, there are possibilities to expand what we can do in blood in a non-invasive manner. And this is a study I was involved and we just presented, and now we're working, expanding these efforts, where we're measuring now interleukin-8 in plasma. And we know interleukin-8 is a very immune-suppressive cytokine mediating neutrophil infiltration into the tumor. We actually published already that interleukin-8 was associated with lack of response in the tumor. And now looking at over 1,000 patients, we were able to show that the baseline level of interleukin-8 is actually a negative predictor of PD-1 axis blockers across at least 5 tumor types in large prospective studies. So again, I think there is a possibility to expand further the non-invasive biomarkers using this type of metrics. And then finally, I will not show you data, but there's emerging data supporting that the patient is also very important, and there are numerous metrics from the patient that influence sensitivity to immunotherapy. One of them being the patient HLA type, and they're characterized now specific HLA types that are associated with better or higher likelihood of response, and also maybe the immune experience. Maybe the numerous times that patients have seen antigen can somehow prime some of these responses, and I give you some references. The second is the global immune contexture, and there are things like the neutrophil lymphocyte ratio and other simple metrics that can capture the global immune state, and some of them are already being associated with sensitivity in lung in melanoma, and the references are there. And there is also a metabolic things such as obesity and habits that are been shown and proven to be also favoring sensitivity and resistance. So this is getting very complicated because now we're looking at multiple things, but I didn't want to forget that the patient and the host is also relevant. And finally, there's a lot of data emerging about gut microbiome, local microbiome, and how that can affect response to immunotherapy, and also drug interactions that may be connected. There is at least data showing that antibiotic use and proton pump inhibitors can actually also modify, maybe interrelated to each other, the sensitivity and resistance. So I think we're going to learn not only from what we can measure in the tumor, we will learn from the plasma, and also we will learn from the patient to ultimately be able to understand and predict and tailor immunotherapy. So with that, I hope I convince you that the current landscape and the future immunotherapy is bright and is rapidly expanding, and I think it's probably the way to go to have successful immunotherapy going forward. That the tumor genomics and the immune phenotype metrics can be integrated, and they're more together than individually. They're non-redundant, and I think they're going to start being used. That their prominent developments allow deep analysis of both intact tumor specimens, circulating biomarkers, and imaging that I didn't have time to talk about. There is a lot of what now we call immunoimaging, immunopet, and there are a lot of non-invasive things that can be measured. And finally, there are novel biomarkers that I'm sure will capture complex immune features and also patient biology over time. Thank you.
Okay, and now the last talk from Dr. Guerin is how are we actually going to do this in 10 minutes?
Right. That's all I need, right? So it's sort of for me, it's a funny two talks today because the one is the sort of driest, where are we now? And the other is sort of a forward-looking and one that's sort of definitely based on one's opinion because there's not going to be a right answer clearly. But how do we move forward? So I think whenever you have a tough problem, you figure out where am I starting? So I think the starting point is that available immunotherapies to date are ineffective in most cancer patients, and that's obviously something we'd like to fix. In addition, a large percentage of patients deriving benefits subsequently recur. So how do we fix these two problems? The best approach, obviously, is to prevent resistance, and that brings benefit to more patients. But one ideal thing is that even in the patients who do achieve benefit, being able to maintain that. The alternate approach, which I think is the one that, as I mentioned earlier, tends to be what we typically start with in drug development, is how do we take people who are sort of out of good options and deal with them, and the ways there are to combat resistance mechanisms and specifically patient-specific resistance mechanisms. So I did have a presentation that I gave a couple of years ago in sort of combination immunotherapies, what's hot and what's not. And I took a few slides from that because I thought it was interesting to look back, and I've modified them only slightly. From that. And I looked back on the timeline, and so what I think people thought was hot in 2014, and I think everything in immuno-oncology was considered really exciting. And then in 2015, then people became a little more selective. It was really everything that modulated the immune system. 2016, everyone realized that anything could modify the immune system, and so we were sort of back to everything. And 2018, this sort of unfortunate, everything that hasn't been added to an immune checkpoint inhibitor in a randomized study is what's hot. And that also gets to some of the problems that we're having in the field. And the question is, do we have the resources, patient resources, economic resources, to keep doing this? And I think that there are sort of different approaches that have led us to this point, and I think they're all well-meaning. But typical approaches in biotech, a lot of times there's a big race. There's a limited amount of funds available. And so the idea is to race through the single agent dose escalation, then go to a dose escalation of the combination, and then small expansion cohorts to look at the agent. And one thing that I think has received a little too much attention, most of the assessments there are with post-therapy radiographic assessments for response rate. The reason this is a big issue is if you're comparing to historical controls and you have 40 people enrolled in your study and only 30 of them have a radiograph, and you do your assessments based on those patients who got radiographs, and you have a 33% response rate because 10 patients respond, when you compare to the historical controls, it's the same as comparing to a 25% response rate, because in a historical control, they would have had to use an intent to treat analysis. So if you started with 40 people, the intent to treat analysis would say 10 patients responding is a 25% response rate. If you only look at the patients who have a subsequent radiograph, if 10 of them don't, which is pretty much what the going rate is for not having a radiograph, you're really not comparing apples to apples in this. And unfortunately, a lot of times one of the things that gets squeezed out when the finances aren't there is the biomarker work. Pharma has taken this sort of different approach, which is often to sort of cycle through a portfolio. They have a lot of drugs available, and to one by one add them to a PD-1 inhibitor. Oftentimes what you're seeing now, which is a little bit new from my original talk 2 years ago on the topic, is the idea is that in the meantime they're developing their own PD-1 inhibitor or partnering with a specific PD-1 inhibitor. And then they're looking for things that have some profound effect across the broad population to go into larger studies. So, well, one group of drugs that has looked good in combinations is drugs that were already effective to start with. And my view, and this is actually essentially verbatim from the slide a couple of years ago, although we didn't have the data at that time, is that established therapies that are of benefit should increase response rate and progression-free survival at least, if not impeded by toxicity concerns. So my sense is that you should see, or maybe not survival, but potentially survival, certainly progression-free survival, and maybe even survival conditions, as long as you have synergy. That would be one way. Number two, if you avoid a lack of opportunity to receive the second drug, because it's better to get 2 effective therapies, presumably, than 1 effective therapy. Or the other thing that can sort of muck this up is if somehow you prevented the effectiveness of the second drug. But otherwise, if you have 2 effective drugs, you're able to give them both. It should improve things. And so far, that's been correct. When we would go to meetings a few years ago and we would talk about these things, I can tell you the things listed on this slide were the sort of boring ideas. The exciting ideas were the dual immunotherapy approaches. But the boring ideas tend to be winning. And so this is an area where we don't have approved therapies yet, but this was an exciting New England Journal of Medicine article by Patrick Ford and colleagues looking at neoadjuvant nivolumab, so nivolumab prior to surgery. In our group, we looked actually at our patients from the Keynote-001 study, whether they received radiation or not, and the radiation previously treated patients actually did considerably better than patients who had not received prior radiation. And now we have the randomized data from the Pacific study showing improvements in outcome by adding durvalumab after chemoradiotherapy. I've already in my earlier talk shown the chemotherapy combination slides for lung cancer at least. And in terms of combining with targeted agents in the area where I treat, which is lung cancer, that has not been a particularly fruitful area, I would argue. But in melanoma, there has been some significant successes in combining effective targeted agents with these checkpoint inhibitors. So what are my concerns regarding the current state of combinations? One, I think that the occasional responder in a setting where we know some patients have atypical radiographic patterns has sometimes led to enthusiasm that has thrown us off course. If you know that there are some people who do have these atypical radiographic patterns, to have 1 or 2 in your study that sort of do better than you would have expected maybe isn't enough to generate tremendous enthusiasm. One thing that I think is important is, for a couple of years, people continued to sort of ask me, what's the thing you need to add to a checkpoint inhibitor that's going to make it work in everybody? And my answer always made them angry, which is probably nothing. There's probably nothing you can add to all of these people and make checkpoint inhibitors effective for all of those people. One thing that I still think, and I'm still not to the point where I've gotten everyone to agree with me, but I think it's going to be really hard to evaluate a combination of drugs when you don't know what one of the drugs does. And so we obviously have a pretty good sense of what PD-1 or PD-L1 inhibitors do at this point. But if your second drug you sort of have very little data on, I think it's going to be very difficult to assess. And this is, to me, sort of the most important issue. I think that if benefits are seen of adding a second agent, it's going to be likely that it would be in a definable subset of patients. So this slide is new because these are sort of based on trends that I think have come up in the last few years. And this is sort of a negative point, but I'm not sure the world needs 80 PD-1 or PD-L1 inhibitors. It's something that is happening because companies are terrified of not having a PD-1 inhibitor. They worry, how will they do combination strategies? But I think there are some pitfalls there. They're very, very similar in terms of what the clinical data is, but sometimes either because of actual real issues or strategy issues, whatever it turns out to be, they can't be used interchangeably. For instance, if one was looking at a PD-L1 inhibitor that you wanted to add to a previously chemotherapy-treated patient, it would have made a big difference whether the agent selected was atezolizumab as a PD-L1 inhibitor or avelumab. One of them is approved in that setting, and the other is not. And so it makes a big difference. Patients who are likely to have a good response to a PD-1 or PD-L1 inhibitor may not be super excited about taking new PD-1 inhibitor X and adding it to drug Y, particularly if you have very little data on either of those. And I think it may be an issue we see going forward. So how do I see that we move forward? I think we need to understand the single agent activity of a drug. I think without that, the likelihood to be able to predict what's going to happen in combination is extremely limited. I would advise people, and this is sometimes how I think about it when I meet with companies who are interested in developing a drug. So in 2010, would I have been interested in developing this drug? And if the answer is no, is it rational that what's happened in the intervening years have made me more excited about it? If so, great. If not, I think it has to be considered. And if we would have been excited about it in 2010, do we need to immediately combine it with a checkpoint inhibitor? Or do we have time to evaluate it more extensively as a single agent? An additional point, I think the generation of a rationale for efficacy of the addition of a second agent should at least in part incorporate patient specimens. So, I agree with the previous speakers who have said it's important to look at laboratory models and improve the laboratory models, but our patients are humans with a human tumor and a human immune system. And I think for evaluating what to move forward with in drug development, this is important. This one I made red, I underlined and bolded it. The biomarker development is, in my estimation, absolutely essential because otherwise I don't see how you get to what I think is most likely to be the winning strategy, which is clinical development of these agents in definable subsets.
Yeah, so it looks like we have a little over 5 minutes left, and maybe I'll start and put this one to Eddie. I agree with you that big red kind of biomarkers are important. So you're designing a study, and you have one core biopsy, and we've heard about all these different biomarkers. How are you going to prioritize which biomarkers you want on that study? Right.
So this is, of course, a major issue, and we face this in lung cancer particularly frequently because in breast cancer, for instance, oftentimes you will have a resection specimen to look at. In lung cancer, we don't. And what I think is that you have to sort of make some guesses as what you think is most relevant for your drug. One of the things that I see that is always hard is you look into a combination and say, oh, and we're going to look at PD-L1 and TMB, and we also want to look at, maybe at a gene expression set for PD-L1 sort of markers. And the question is, well, if your drug is something different, don't you want to be predicting the efficacy of your second drug? And I think that from my perspective, it's going to differ by the drug, but I think it needs to be specific to what the anticipated mechanism of action of the agent is. Yep.
Kurt, how about, so this person asks, what would you recommend to those who are unsure what platform to use at an institution that currently doesn't test for PD-L1, MSI, or TMB?
So this is a difficult question because it depends on resources and the setting. I think what many academic institutions have decided in this sort of complex landscape of multiple platforms measuring the same biomarker is to develop LDTs. And there are many institutions that instead of deciding to use and bound to one PD-L1 assay, they have standardized things like E1L3N that has been shown in numerous studies to be comparable to the other, but it's not attached or binding to a specific drug. Relative to microsatellite instability, I think for now, we know what works. And immunohistochemistry has shown to work. It has some limitations, and the molecular test works, and it's heavily available. I think what's happening now is that the tumor mutational burden is being built into the sequencing assays, and so is microsatellite instability. So it's most likely that the discrete single MSI assays will fade away, and this metric will be incorporated in the sequencing panel, and it's actually obtainable in circulating tumor DNA. So I think that will happen.
This next question says that new combination trials evaluating novel therapies with PD-1 are usually added to patients who have already progressed on standard of care IO agent. If a patient has a response on the new IO agent, how do you interpret their response?
Yeah, so I think that there's been there's been an assumption, which I think is fair, that you're unlikely to continue to respond. And at least when I put together sort of a grant or a study where I need to sort of power, I sort of use around 5%, which is the metric that the FDA says is what you will see for progression, for response to nivolumab. I think was the drug specifically they looked at, response for nivolumab if you already progressed on nivolumab as part of the clinical trials. And so I think that in general, that if you're consistently beating a number like that, you should feel pretty good. On the other hand, if you have 10 patients and you have a 10% response rate, I don't know that that's enough to get real excited about. But again, just to defend the idea of looking for the biomarkers, as you pointed out, the response rate in colorectal cancer in the original nivolumab study would have been about 3%. But knowing who that 3% is makes a huge difference. And so I think that can really help you separate out what's noise in this setting from just a raw percentage.
And so in the very last minute, I see a number of questions, asking about, what is the right cut point for TMB? How would we use that moving forward? And I think that is one of the questions. I think that, and hopefully we've tried to illustrate, with the range of different cut points that have been evaluated. And I think the answer is we don't know yet. And again, it's such a crude view. It's the 50,000-foot view of the tumor, and so I think we need much more granular estimates to take and move forward with. So I think we could spend a long time here tonight and keep answering questions, but I think for the sake of time, we're going to bring this to a close. Thank you so much.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/FQK860. This activity is supported through educational grants from Bristol Myers Squibb, Foundation Medicine Incorporated, Insight Corporation, and Merck & Company Incorporated. This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peer View Institute for Medical Education.